My name is Darren Carell. This brief presentation goes well beyond what one needs to know in terms of understanding how to safely use opioids. It contains information that is based on the state of the research literature as best as I'm able to gather. It's solely offered for those who want a deeper level of understanding of opioid receptors for any reason, including a look into potential future medications. It could also be used to treat insomnia in some people. This table shows which opioid receptor subtype is known to be responsible for the three major effects from opioid agonist use: analgesia, broken into spine and brain mediated, respiratory depression, and euphoria. Agonist binding of the mu receptor is responsible for all the major effects: strong analgesia mediated through brain mechanisms, intermediate analgesia via spinal mechanisms, plus a high degree of respiratory depression and euphoria. Every clinically used opioid agonist has all or the majority of its activity by binding the mu receptor. Agonist activity at the kappa receptor results in weak analgesia through activity in the spinal cord. Notably, it does not cause respiratory depression or euphoria. Presently, there are no pure agonists of just the kappa receptor for clinical use. The primary mu agonists, morphine and levorphanol, do have moderate activity at kappa. Tramadol has a minimal amount of activity, as may meperidine. Of the mixed agonist-antagonists, pentazocine is a full kappa agonist, whereas butorphanol and nalbuphine are partial agonists. Delta agonism results in weak analgesia through brain mechanisms and intermediate analgesia through spinal cord activity. It does result in a low degree of respiratory depression, but not euphoria. Like kappa, there are no pure agonists of just the delta receptor for clinical use. Again, the primary mu agonists, morphine and levorphanol, do have moderate activity at delta, and tramadol has a minimal amount of activity. Of the mixed agonist-antagonists, butorphanol is a full delta agonist. Agonist activity at the nociceptin receptor appears to have an intermediate analgesic effect through spinally mediated mechanisms and be devoid of respiratory depression and euphoria. As you likely guessed, there are no pure agonists of just the nociceptin receptor for clinical use. The only agonist that may be a nociceptin agonist is levorphanol, and the mixed agonist-antagonist buprenorphine is likely a weak partial agonist. Mu opioid receptors have multiple other clinical effects. These are discussed in the opioid pharmacodynamics video in this series. Kappa opioid receptor agonists, despite only providing a mild degree of analgesia, the fact that they do not cause respiratory depression or euphoria, in addition to having anticonvulsant effects, could make them attractive to develop. Unfortunately, they do result in sedation, can cause dysphoria in some people, have dissociative hallucinogenic effects, and can give rise to depressive symptoms. Delta opioid receptor agonists, the moderate analgesic effects and lack of euphoria, plus having antidepressant effects, make these appealing for development too. They do result in physical dependence, reduced GI motility, and can produce minor seizures. However, the latter is blocked by giving a mu agonist at the same time. They have mild respiratory depression themselves, but may modulate mu opioid receptor mediated respiratory depression. A mu agonist plus a subanalgesic dose of a delta agonist results in synergistic analgesia. So the proper combination of mu and delta agonists could result in good pain control with a limited dose of mu agonist thereby attenuating the development of respiratory depression and maybe tolerance, and without resulting in seizures from the delta agonist. Nociceptin opioid receptor agonists not only have moderate analgesic effects on their own, they appear to enhance mu-opioid receptor-mediated analgesia. Their lack of respiratory depression and euphoria are promising, but they do cause anxiety, depression, and potentially play a role in the development of tolerance to mu agonists. So, if we go opposite to thinking only of agonists, selective nociceptive antagonist can attenuate mu tolerance. I hope you learned something from this talk. Please look for the other presentations in the opioid pharmacology series on the website. And as always, thanks for watching.